Hammis. And we're going to, is it okay?
Yep.
Thumbs up. We are recording, okay? So these presentations will be on our website for folks to use. I forgot.
Thanks, Judy. It's a real pleasure to be here in Tennessee again. I was here last fall, and as Judy said, I've been working with your statewide group to try to improve the spread of the use of the post, as well as make it a sustainable program. The presentation that I want to give today is really going to address the relationship between the use of advance directives, which would include the living will and your power of attorney for health care, to the post. Maybe many of you in this room are not confused about this, but this is an issue of general confusion both by clinicians as well as the general public. And it's not uncommon when I go out and consult for people to say, well, why don't we just use one or the other? Why do we need both of these? What's their relationship? And so I want to address some of those issues, both looking at them.
I was looking at lights. Excuse me, I was trying to get a little darkness right here.
Let's see. Lights. Better?
Is that better? Can you see it better?
So this is going to be my general theme, that post is an effective component of a comprehensive advanced care planning program. So it's a component of a larger activity in which we help patients and their families prepare for future medical decisions. And the evidence shows that it's an effective component. What I want to argue is that it is only one component, and that to have a really good program, you also have to spend some time and concern about helping people create particularly some type of power of attorney for health care. Judy was talking about the spread of the post paradigm. So you guys use the language of post, physician's order for scope of treatment. The program originally developed, let's see if I can get the pointer, out here in Oregon. Crosse, which is represented here, and as you can see in Wisconsin, the use of this paradigm is only a regional program. We have not yet been successful at getting statewide legislation. We were actually the second place in the country to implement a pulse paradigm program. But as of May 2013, you can see that much of the country is at least light pink, which are developing programs. The dark pink states are endorsed programs that are up and running and meet all the criteria. The kind of dark purple ones are mature programs that have met certain outcomes, and then certain states like Minnesota and I believe Maryland have pulse-like programs. So they're using a similar approach, but have not either wanted or have not achieved meeting all of the criteria that the Pulse Paradigm Task Force has set down as criteria for the Pulse Paradigm. The reason these criteria are important from the National Task Force point of view is that we believe that the criteria establish the best practice based on evidence. Some programs disagree with us and have kind of drifted off, but we want to have some standardization and some evidence for those criteria. In the states that are white, we just either have no contact with those states or there is no identifiable effort at this point to move forward. But if you look at the series of maps over the last 10 years, it's been quite remarkable at the progress that's been made at the spread of this particular paradigm across the country for clinical practice. So my first kind of theme here is that if we want to look at this broader concept of advanced care planning, that process of interacting with people and their families about future health care, there's a few things that I would like to assert. One is that this is not a one-size-fits-all discussion. We can't just go and say, well, this is what everyone needs to do and this is how they need to do it. We need to individualize these discussions in large measure. And it must be individualized to, first of all, the person's readiness, as well as to their stage of health. So how we discuss and what we discuss can't be just driven by a document or a form, whether that's the post form or some type of advance directive form. We have to think about this as a clinical interaction with the person we're working with and those who are close to them, and figure out, first of all, what are they ready to discuss? Our experience in La Crosse has been that if we don't identify the fears, the concerns, the gaps in understanding, the misunderstandings that people have, we really can't make a whole lot of progress in doing good planning. So just as a simple example of this, one of the common barriers that we identify when we're doing general advanced care planning is we approach a person, we're suggesting they do some advanced care planning, they seem receptive, but then in the end they go, no, I don't think I'm ready for this. And of course it's their legal right not to do this. But if you actually ask them, well, what's the issue for you? Why aren't you ready to proceed? They'll say something like, well, you know, I know this is a good idea, but I'm not ready to give up my own personal decision making to someone in my family. And you go, well, tell me what you think happens here. Well, you know, they think what happens is that as soon as they sign a power of attorney for health care, the person they appoint takes over, and they no longer can make decisions. Well, if that's what you believe, you're not going to sign this document. You're not going to proceed forward. But as I think we all understand, that's an incorrect understanding. That's not what happens. And until you identify that gap in understanding, you're not going to proceed with that person no matter how much you talk to them. So individualizing care planning means that we listen to the person, and so we can identify these gaps, these misunderstandings, these fears, as a way of proceeding forward. And I'm going to talk about the stage of health in the next slide. We also think that this interaction with the patient requires highly developed skills that address different stages of planning. Very few people, if any, were taught in their health professional training how to do this. It is a specialized skill. And yet, we often read in the literature, doctors should do this, or someone should do this, and there's this kind of, you know, direction that we should be doing this, and it's good to do this, and it's becoming a standard of care to do this. But how do we do it? How do we do it well? How do we make sure the plans that we actually create with our patients are well developed, well thought out, and actually represent what these patients want? Well, we believe that that is a skill, and it can be taught, and it can be standardized so that we can really enhance the practice of advanced care planning as part of routine health care. So one of the ways we do this is to think about how patients proceed from health to death through typically now a prolonged stage of chronic illness. So if this is time one when people are pretty healthy, this line represents the progression of a chronic illness where the dips represent hospitalizations or acute episodes, and ultimately at the final time, the patient dies. And so this represents what over 80% or 85% of us will go through in the last years of a life. A progressive chronic illness that gets worse, and we lose function and capacity over time, punctuated by many hospitalizations. This well-defined and understood graph of how most of us will die can really help us organize how we do good advanced care planning. So, and we can argue about the details here, so I don't want to get too much into whether this is exactly right, but I want to propose that these three stages are distinct and important, and we need to organize advanced care planning around them. So the first step of advanced care planning is focused on the bottom here on healthy adults between ages 55 and 65, or younger people who develop a serious incurable illness that will progress at an earlier time. But these days, most of our population are going to reach their midlife in relatively good health. And this is early enough to do good first steps advanced care planning. Now, what's the outcome of this planning, this process of planning? Well, to create a power of attorney for health care in which at least two things are done well. The first is to select and appoint a well-chosen representative who can make your health care decisions if you fail to make them yourself. Not just selecting anyone or selecting the first person who comes to mind, but really thinking out, is this person willing? Is this person able to make good decisions and to make them sometimes in complex situations and sometimes under a lot of distress, perhaps even conflict with other family members? Could they carry out these responsibilities? It's surprising to me, but true, that when you start to talk about these qualifications, about 20% of patients we ask say, oh, no, he couldn't do that, she couldn't do that. That is, they do not consider these qualifications in their initial selection process. And so good facilitation and good planning requires us to actually inquire, is this person capable of carrying out these responsibilities in the circumstances? Are they willing to carry out these responsibilities? Are they willing to have a conversation so they understand your values and goals? These are the kinds of criteria, and when we ask, we get better selection of the healthcare agent or advocate. The second thing we want to do at this stage of planning, the first stage, is to talk about when a severe permanent neurologic injury would be considered so bad by you that the goals of care would change from trying to keep you alive to simply focusing on your comfort, even if that resulted in your death. This particular decision is important for even healthy adults because it's the one decision we never get a second chance at. That is, if a severe permanent neurologic injury occurs, we can't ask the person another time, what do you think about this? And it's the one decision that families understandably struggle with because often our medical treatments will keep them alive for long periods of time. But should we do that? It becomes clearly a moral decision about what is the best thing to do for this person. And without that person's input in advance, we end up guessing. All other decisions almost always get a second chance. What do you want if you have severe incurable cancer? Well, I don't know, but I'll be able to answer that question when I get severe incurable cancer because I almost never lose my capacity at the beginning. So we try to really focus and narrow this first stage of planning to those things that are most important and absolutely essential, and leave other decisions to later stages. The second stage we call next steps. Next steps is focused on adults, on the bottom here, with progressive life-limiting illnesses suffering frequent complications. So as you can see, they've now had 2 or 3 hospitalizations. Their functional level is declining, and it's becoming more and more difficult to manage their disease medically. What do we know about such patients? They're going to have more complications. It's not a question of if, it's just a question of when. And while we may not be able to predict well when these things are going to happen, we know they will happen. And even when we do our best to manage these illnesses and treat the acute episodes, some of these patients are going to suffer complications and have bad outcomes. So this stage of planning is focused not on limiting treatment, but on when an outcome would be considered so bad that the goals of care would change. So if this person has worsening congestive heart failure, and we know they're going to come back to the hospital on occasion, and we plan to treat them aggressively as possible, what we want to prepare for in next steps is, if we treat you and things don't go like we would want them to and you would like them to go, when would that be so bad that we would change our goals of care? People can answer this question. Now, they answer it differently, and that's why it's important to plan. Some people would say, this is my limit, and in the same circumstance, another person say, no, keep going. I'm okay with that. And because of these individualized differences, we need to plan. And this tremendously helps the family and the providers and clinicians know what to do when those unexpected but bad outcomes occur. And then the final or last steps of planning is when we wouldn't be surprised if an adult would die despite our best efforts in the next 12 months. Here, what we want to establish is a very specific plan of care expressed ideally in something like the post form. So for each stage of the planning, we are increasing with specificity. We're individualizing it to that person's stage of health so we can plan more clearly. Planning ahead for what I would want right now if I had congestive heart failure, how the hell am I supposed to know that? I can't plan for that. It would be unreasonable to ask me. But if I've been hospitalized 2 or 3 or 4 times for congestive heart failure, and I've been through those interventions, now I can really start thinking pretty clearly about what that's like and whether I want to go through that again, or if the outcome were this or that, whether I would want to keep going or not. It's reasonable now, as we go through this, to get more specific because people are diagnosed with that illness. It's getting worse. They understand the process, and we can adequately inform them about the benefits and burdens of treatment as that progress goes forward. For each stage of planning, we have created a training program for what we call advanced care planning facilitators. People who can help the process of thinking and reflecting so that people can make well-informed plans that really reflect their values and goals. So let's talk about a story here and kind of see this in kind of practice, and none of this will be surprising to most of you. So this story actually comes from an article written by a well-known physician, end-of-life specialist, Joanne Lynn. So she describes a 71-year-old man with severe chronic obstructive pulmonary disease and mild dementia who's admitted to a nursing home after a hospital stay for pneumonia. He develops increasing shortness of breath and decreasing responsiveness over 24 hours, and the nursing staff call the emergency medical service, who find the patient unresponsive with a respiratory rate of 12 breaths per minute and an oxygen saturation of 85% on room air. For those of you who are not clinically inclined, this man's pretty sick, and he needs help if we're going to help keep him alive. Now, the patient at admission to the nursing home discussed his desire to forego aggressive life-sustaining measures with his family and the nursing personnel and completed a power of attorney for health care. Although a do not resuscitate order was also written into the medical chart, the emergency team was not informed of this order, and there were no orders for respiratory failure at all. So one of the most expected things to happen to this man, given his underlying disease and past history, is to have respiratory failure, and yet no one discussed this with him. The emergency team, therefore, inserts a tube into his airway, administers supplemental oxygen, and transports the patient to the emergency department of a local hospital. The patient remains unresponsive, and his chest x-ray shows large lung volumes with consolidation, indicating that he probably has pneumonia, and his blood gases show marked respiratory acidosis. Again, he's in medical trouble here, and if we're going to keep him alive, which would be the understandable assumption of the emergency room physician and any hospitals taking over his care, because they have no other information about what the goals of care are. So the emergency department physician writes, full code for now, status unclear, the patient is intubated, sedated, and transferred to the intensive care unit for further support. This is not an uncommon story anywhere in the United States. So what went wrong in terms of our care of this man? Well, a lot of things went wrong, all of which are fixable or changeable. First of all, the do not resuscitate order was not communicated very clearly within the healthcare facility and to the emergency team who came to take over care. There was a lack of clarification of no aggressive treatment with the patient. What does that mean? If he doesn't want aggressive treatment, exactly what does that mean? Here we need very more specific. Sorry. Thought I had put that on vibrate, but I guess not. There was a lack of eliciting wishes for all relevant treatment decisions, for example, airway management, hospitalization, and comfort care. So there was lack of clarity. So as a result, the patient received care that he may not have wanted, appeared not to have wanted, and what we did know about this patient's wishes were not actually communicated well in the transition of care to the ambulance and to the emergency room in the hospital. This is what the POST program is intended to fix for these folks who are in their last year of life. So this is not an either-or decision, but these are the differences between a power of attorney for health care and a POST. So a power of attorney for health care is a document completed in advance with decisional patients or people and individuals. The POST, on the other hand, can be completed by a decisional patient, but it also can be completed by their legal representative, their designated surrogate. So it can be completed by a wider range of people, and I'm going to show you some data here in a minute that shows you what why that's important. The power of attorney for health care is only implemented when capacity is lost, whereas the POST is immediately available to guide decision making, whether the person has capacity or not. The power of attorney for health care provides some general goals in care plans, where the POST provides very specific orders for what to do and not to do for the sickest patient. It stays with the patient when we move them. And of course, the power of attorney for health care designates surrogates for future decision making. The POST is in effect immediately, but I want to make clear to everyone, because I think this is sometimes not well understood, it can be and should be updated by any physician in transitions of care as needed. So when I bring up, for example, our emergency room physicians to talk with visitors, and we have a high volume or prevalence of pulse, particularly with patients coming from hospice, home hospice, or from nursing homes, they always check to see if the pulse is in effect and if it still represents that person's wishes. And either they're talking or confirming this with the patient, if they're capable, or with the healthcare agent who's been appointed. So the fact that these things are immediately actionable, is the words often used, does not mean that people are not checking in transitions of care of whether they still are the right orders to follow. And orders often get changed based on changing health conditions. So these are being updated, reviewed, and evaluated. So they're there, they're available to make decisions. They often influence how decisions are made, but also their validity is validated through transitions of care. So what I want to argue that both of these documents have importance and values in our providing the best care to patients. As you know, the goals of the POST program are to provide timely opportunities for informed and specific end-of-life treatment decisions, but for a particular group of patients. For those who have serious life-limiting illnesses, those that are clearly terminally ill and dying, for those with advanced frailty, and in some cases for others, particularly of those of advanced age who have interest in defining their care. This is not for healthy adults. This does not substitute or in some way become an alternative program for a power of attorney for healthcare. This would be the primary question, and this question actually has evidence behind it. People have studied this question. So this is a good trigger question. If a clinician caring for this patient would say, you know, given what I see, my general gestalt in terms of the laboratory, the past medical history, our challenges in managing this ill, I would not be surprised if this patient died in the next year. If the question is no, I wouldn't be surprised, then you have someone who clearly should at least be offered the opportunity to do a pulse form. The key features of the program are it serves as a set of medical orders. It's not just a statement of preferences. They're actually orders signed by the appropriate clinician. It's portable. That transfers from one setting to another with the patient or the resident. The importance of this is that as that transition occurs, everyone who lays their hands on and assumes responsibility of care for that patient can follow these orders. A power of attorney for health care is worthless in an ambulance. Ambulance paramedics and EMTs are not authorized by any law that I know of to make any decisions based on a power of attorney for health care. They have to follow their protocols, and those protocols in states that authorize pulse allow them to follow the pulsed orders. It provides directions for both providing or foregoing aggressive treatment. A study just came out of Oregon which has a registry and has tens of thousands of pulse documents in their registry, and they can see what happens now on a fairly reliable basis. And what they found is pulse forms that said attempt CPR led to CPR being attempted more reliably than patients who had no pulse form at all. Okay? So many people will say, well, if you want to be a full code, you don't need a pulse form. And that seems logically true. What they found is that if you had a pulse form and it said, attempt CPR, I want it, you were more likely to get it than someone who had no pulse form whatsoever. And so what this suggests is that if you really want CPR attempted, and you are perhaps in a category of being a sicker patient, it's better to communicate that and say, I do want this, and you're more likely to get it. In Crosse, where we looked at deaths of people who had pulse forms, we found 5 pulse forms that said, I want CPR and I want full treatment in Section B. All 5 of these patients resided in nursing homes. All 5 of them, when they got sick, got sent to the hospital. All 5 of them, at admission to the hospital, had full code orders for the hospital. All 5 of them got aggressively treated. In all 5 cases, however, despite aggressive treatment, treatment failed. And in all 5 cases, there was an additional conversation at the hospital, either with the competent patient or with their legally appointed surrogate. And in the light of the failure of treatment, another decision was made to withhold or forego treatment, and the patients died. But their pulse form was faithfully followed until it was clear that treatment would not work. That's what they wanted. That's what they got. And I would contend that having that order for full treatment served them in the way that they want it to be served. So even for people who want full treatment, I think those who are in the sickest category, it's better to have a pulse form stating that and to communicate that clearly. Obviously, pulse forms serve as a do not resuscitate order, but also provide goals of care for severe cardiopulmonary deterioration. Now, does this work? And there's been one large study in which I was one of the investigators. The PI was Susan Hickman. And in this study, we looked at the use of the pulse paradigm in long-term care facilities in 3 states that had wide implementation of pulse and good penetration: in Oregon, in West Virginia, and Wisconsin. Now, Wisconsin's unique because we could study a region where pulse was very penetrated and compare it to a region in which they had no pulse program whatsoever. And so what we wanted to look at is long-term care facilities that use the pulse paradigm versus long-term care facilities that did not use that and just wrote orders in the standard order sheet in the nursing home. So what did we find? So we looked at, in the 3 states, nearly 1,800 subjects or residents. Some of these, about half, were already deceased, and half of them were still alive but had been in the facility for at least 6 months. And if we just looked at, did they have any orders about life-sustaining treatment, if there was a pulse program, 100% of the time there were orders, only 86%, and this had a p-value of 0.001. Now, this doesn't probably tell too much. I mean, it seems significant, but this slide, I think, really tells you what the difference is. So here, regarding resuscitation, now, I'm not saying that these are all DNR. They could be full code. It's just that there was an order. When there was a post program in that nursing home, 100% of the time, there was an order. In the other facilities, it only occurred about 86% of the time. But here's where we found the biggest and probably most important difference. In Section B, when there was a post paradigm, 98% of the time, there was some order. Now, these orders could be for full treatment, or for comfort measures, or for limited intervention. Could be one of the 3. We only found such similar orders in about 8% of the traditional practice. So if we want to say, is there a difference of using the post versus not? Yes, there's a very significant difference. Oops. Did this make a difference in what happened to the patients? And again, the answer is yes. In the nursing home, where there was no post-paradigm program, 26% of the residents received life-sustaining treatment, only 16%. And when we layered these out by the type of order in Section B, what we found is those who had comfort measures only got the lowest amount of life-sustaining treatment. Those who got full or wanted full treatment got the most life-sustaining treatment. And those who wanted full treatment in the pulse received about the same amount of life-sustaining treatment of those who had a code order in the nursing home. The interesting thing is those who had a no CPR order in a non-pulsed long-term care facility received the same amount of life-sustaining treatment as those who were full code and those who were full treatment. So having a DNR order in and of itself doesn't change much or anything of what happens to people. Actually, just by the numbers, people who are DNR in traditional nursing homes without a pulse paradigm receive the most life-sustaining treatment. And what I think that means is that if you're a resident in a nursing home and you are a DNR and you start to get sick, you get sent to the hospital before you have a code, most of the time. And you're going to have a lot of stuff done once you get to the hospital because the DNR doesn't stop much, except maybe CPR, which is all it's intended to stop. Section B is the section in the pulse paradigm that makes the difference in how we care for patients. Now I'd like to look at our community in La Crosse, where we have some of the highest penetration of advanced care planning in the country. And I want to show you how this can work and how good advanced care planning is has many components to that. So We started our program in La Crosse in the early 90s, and we had full implementation throughout our community in 1993. In 95 and 96, we looked at every death in La Crosse County of adults who were residents of La Crosse County and died in any healthcare setting. So this would include home hospice, long-term care, 7 different nursing homes, 2 hospitals, and any home health agency. So if a patient was an adult who was a resident of La Crosse County and died in any healthcare setting or organization at the time of death, they were eligible, and there were 540 deaths that we tracked over 11 months. This is not a sample of deaths. And we know it's not a sample because we had access to death certificates on a day-by-day basis. We could track everyone who died through the death certificates, and we know for certain that this is all of the deaths that were eligible, and we tracked them all. We also had access to every medical record that this patient had at every health organization, and we looked at them all. What did we find? That 85% of these deaths had a written advance directive at the time of death. 95% of those documents were in the medical record of the health organization who was caring for them at the time of death. And when we looked at the refusals of treatment in those documents, the refusals of treatment were followed consistently in the orders that were written 98% of the time. So we had a high prevalence of planning. Plans were available to the health professionals caring for the patient, and the refusals of treatment were consistent with the treatment decisions. We repeated this study. Some people said, I got lucky. That's really nice. You did it 1 year. Did you sustain that? So we repeated this study in 07 and 08. This time we had a smaller number because we had less money. We only could track 7 months of deaths rather than 11. But the study was repeated, same population, same area. Now we had increased the prevalence of planning to 90%. The availability in the medical record was now 99%. I'm not sure we can get better than that, and I don't think we can get better than this. And in the second study, we actually looked at requests for treatment as well as refusals of treatment. So we looked at a broader range of preferences. And now we had a 99% consistency between what the patient said they wanted or didn't want and the treatment that was or was not provided. Between these 2 studies, we implemented the PULSE paradigm. We call it PULSE in La Crosse. And what we found is that in addition to these patients, 90% of them having an advance directive, nearly 70% also had a PULSE form. These forms were available in the medical record at the site where they died nearly 99% of the time. What this means is that if the patient was in long-term care, was sent to the hospital, and then died in the hospital, the PULSE form was in the hospital record where they died. If they died in hospice at home, hospice had a copy of that PULSE form. So these PULSE forms were not only completed, but were available to the clinicians caring for the patient. These PULSE forms were completed with a mean time of 4.5 months prior to death. So the PULSE form that was in effect at the time of death was created just months before. So these orders were typically reflective of the patient's health condition at the time of death. And if we ask the question, how many of the decedents of the 400 had either some type of advance directive or some type of PULSE form, we found that 96% had one or the other. There were only 4%, or 16 people if you do the math, who did not have a written care plan in our community at the time of death. So I looked at those 16 people, and here's what I found. 8 of them had been approached to do planning and refused. It's their legal right to do that. The reasons they refused varied from cultural to denial. There was one patient that sticks out in my mind who was about 53 years old. He had diagnosed with a rather aggressive, incurable cancer. He could never accept his diagnosis. And doing advanced care planning in his mind was admission that he was sick and dying and he couldn't go there. Patients will be like that. Some patients cope better through denial than any other means, and we have to respect that. The other 8 patients who had no planning were typically much younger people who had no previous illnesses and died unexpectedly of traumatic or sudden illnesses like heart attacks or strokes. Now, in my experience, even good advanced care planning would not have changed what we did for these patients. So I'm not sure that we can say we missed much of an opportunity with those 8 people. So what were the differences in the demographics of the people who had a pulsed or post form versus someone who only had an advance directive in these 400 people? This is where I think you can see why these are complementary programs. The pulsed population was much older. The mean age was 83 versus 77. The pulsed population had clear diagnosis of either chronic, progressive, or terminal illnesses at the time of death, which preceded their death. We knew that they were at the end of life because they already had these progressive illnesses. The people who only had an advance directive had a higher percentage of people who died suddenly or of traumatic causes. And while we didn't look at this specifically, my guess is that even if they had chronic illnesses, they were much less severe than the pulse population in terms of degree of illness. So in my opinion, the 116 people who didn't have a pulse probably weren't candidates for pulse. They just weren't sick enough yet. They still died, but we couldn't predict that. We were surprised that these people died. People who had a pulse were more likely to die in long-term care or at home, typically home hospice. People who had an advance directive were more likely to die in the hospital. Well, that's not surprising. They were relatively well, they got acutely ill, they deserved to go to the hospital. They received aggressive treatment. The pulse form, about almost a third of them, were completed by a healthcare agent alone. So what does this slide tell us? Well, oops, I'm sorry, why did I do that? For the people, 116 who had an advance directive only, my guess is that we would not have seen them as candidates for pulse forms, and yet they died. And probably in that dying process, they lost capacity at some point. And it was valuable to have a healthcare agent there who understood their values and goals, who could help us in those unexpected and important decisions. So about a third of patients are going to die without a pulse form, no matter how good we are. And having a power of attorney of healthcare in place is going to help us in those acute episodes where they die because treatment simply fails, to guide us in the decision making. And another third of patients will need a healthcare agent to complete their final pulse form because they're going to be unable to do that on their own behalf. So it remains important, I think, in our work to encourage and promote the use of powers of attorney for healthcare for those people who die sooner than we expect. So we have a decision process and some general plan in place. And the power of attorney for healthcare remains important once people become kind of pulse eligible, because that last form is going to need to be completed probably without the assistance of the patient in about a third of cases because they have lost mental capacity to do that for themselves. So pulse is important for people at the end of life. to get a very specific plan which transfers across settings of care. The power of attorney for healthcare is important prior to that, but also at the level of a PULSE program to make sure we have a well-identified and good decision maker to represent that patient when they lose capacity. Now, I just want to finally talk about some kind of nuts and bolts here. When we talk about training people to use the POST program, we really need to keep in mind there's really two types of training, I think, that we have to provide. One training, I think, is obvious. How do you complete the form? How do you manage the form within the organization? And how do we manage the transfer of the form from one organization to the other? What's that system look like, and what are my responsibilities in working in that system as a health professional? We have to train people to do that. But we also have to train people about how to work with patients and their families or with the patient surrogates to make informed decisions that are reflective on the POST form. That facilitation skill to make the decisions, and I'm not talking about how to check the boxes here. The PULSE form is a form that communicates information. It is not a decision tool. And I think we make a great mistake when we start considering the PULSE form as a decision tool. It is not a decision tool, it's a communication tool. The decision process has to be guided by someone who understands the decisions and how to help a patient and their family or a surrogate work through those decisions. In most programs nationally, non-physicians play a central role in facilitating discussions and decisions with patients, their families, and patient surrogates. Whether we like this or don't like this, whether we agree or disagree with it, this is true, and I don't see any way of changing it. Physicians simply do not have enough time to spend with patients and their families, which take at least 60 minutes, maybe longer, to work through. And so the only approach that we have found that is practically possible is to actually train non-physicians to play a new role of advanced care planning facilitator to make these decisions about the PULSE form well, make sure they're informed, make sure that they're thoughtful, that they reflect the patient's wishes, so that when we mark the PULSE form to communicate those decisions, it's marked correctly in accordance with the patient's informed decisions. I'll talk briefly, in about different settings. In long-term care, these are the things that we need to look at. Is the POST being reviewed at admission and updated over time? Is there a clear and standardized place to maintain the POST so all can see it and know where it is? Does it go with a resident when he or she leaves the facility, especially to an emergency department? So in our community, if a patient leaves the facility to go see their doctor for an ambulatory care, the form goes with them. If something happens in that clinical visit, the form is there to present the clinical people who come to that emergency. Are people assisting with the PULSE decision trained to assist? And how is the POST reviewed when a new resident arrives, and how is the POST employed when there is an acute problem? One of the key problems we've identified in La Crosse is a resident of a long-term care facility who had a POST in place would get sick at 3 in the morning, and someone on the staff would call the family. And the conversation appears to have gone something like this. Your mom is getting sick, she may have pneumonia. If we don't do anything, she's probably going to die. What do you want us to do? Well, at 3 in the morning, how is a family member going to answer that question except send her to the hospital? The way that conversation might go is something like this. Your mom is getting really sick. We think she may have pneumonia, and she could die in this episode, so I'm calling you because we know you might want to come and be with her. We have a POST form here that tells us that we aren't going to attempt CPR. We're going to make her comfortable, and our focus is going to be comfort. We believe that that's the plan that's in place and that we are going to follow. Now, the family might say, oh, we've changed our mind. We disagree. I understand that. But at least the person calling needs to be trained to say why they're calling, that a pulse plan is in place, and it would be our understanding that that's the plan we're going to follow. And if there's going to be a change of that plan, then there should be a discussion. So how the family is informed during an emergency from a nursing home is as important as having the plan in place in the beginning. Admission to the hospital. If a patient has a post form at admission, does the admitting physician know this? Does the physician in the ER? Is this handoff actually occurring, and is it reliable? Are the existing post orders appropriate to the written medical orders for this admission? In most places, you have a post when you get to the hospital, but the admitting physician has to review those orders and then write appropriate orders for the hospital stay. They may reflect exactly what's on the post form, or they may be revised because of discussions with the patient or the patient's surrogate. Is the post form kept track of and either updated or returned to the person, with the person at discharge? So these are the functions that should happen at the hospital. Now, at Gundersen, we've developed code status orders for our hospital that are similar to the orders in section A and B of the post form. So we have something we call PDNR, which is equal to DNR on section A and comfort measures only. So our code status orders in our hospital don't just deal with CPR. They also deal with severe cardiopulmonary deterioration. So let me just explain this. So what we call ODNR is equal to DNR and aggressive treatment. This is an order that's frequently used in the ICU for patients who are not doing well, and if they had a cardiac arrest, we believe that adding chest compressions won't change the outcome. They'll still die. But the fact that they're aggressive treatment means they can be intubated, they can have pressors, they can be on monitors, and they can receive any other treatment to try to prevent them from having a cardiac arrest. So we have now tailored our hospital orders to be similar to our community orders, so that as people move from the hospital out to the community or back, we have a way of capturing those orders effectively in both settings. In home hospice, again, these are the kind of system issues that need to be considered. And then emergency services also have to play their role. Our first responders and EMTs trained to use the post. Is this training updated on a regular basis? Do they ask for or look for the post form when called to a scene with a patient who might have a pulse? So I can tell you from experience in La Crosse, when we found my wife's aunt down with a massive stroke, and we called 911 because she needed to be assessed. We didn't know for sure what was going on. We were able to present the form to the paramedics so that as they transported her and then brought her to the emergency room, that care plan followed her, stayed with her through the transport and into the emergency room. Now, when we got to the emergency room physician further discussed that plan with us and whether or not there was any reason to revise it, change it, or modify it in the current circumstance that we were facing. So those are some of the considerations when you're implementing about particular things that you need to attend to in your setting of care. In the end, I'd like to just emphasize that this approach sees powers of attorney for healthcare and the post form and program to be complementary and both to be essential and important. It requires us to do different levels of facilitation and planning with the patients and their families. And we have to have systems in place so this information is reliably stored and flows reliably across settings of care, so that as patients make transitions of care, the next clinician, the next provider is aware of what that plan is and can take that information into consideration in providing the right care for that patient. I'm going to stop there so we have some time for questions and discussion. Thank you.